Medical Record Pre- and Post-Abstraction, presented by Stefan Villavicencio for the National Birth Defects Prevention Network. Training Overview. This webinar is designed to train program staff who need to collect information from medical records for population-based birth defects surveillance. We will cover fundamental aspects of abstracting information from medical records, approaches to collecting pertinent medical data, quality assessment of abstracted information, and resources to aid with the data collection process. And now let us begin. Introduction to birth defects surveillance. Especially for new staff, these basics can orient abstractors on how to begin. If you are new to abstraction, you will find that the art of abstraction can involve putting all of the pieces of a puzzle together. Case abstraction. What is case abstraction? In the broadest sense, it is the process of recording required information about cases that meet the surveillance case definition per program objective. Program case definition criteria. This is the criteria used by a surveillance program to include birth defects. This definition can be defined at the national level as well as at the program level. Programs may modify their own case definition to be consistent with their own program's needs, objectives, resources, legislative authority, and funding. Changes in the case definition may be driven by changes in funding, as well as by emerging public health issues. The Zika virus threat was an example of an emerging public health issue that led to a re-evaluation of the case definition criteria of microcephaly at both the program and at the national levels. Another recent emerging public health issue was the opioid epidemic and its effect on neonatal abstinence syndrome. Prior to that, there had been a renewed interest in screening for critical congenital heart defects. Keep in mind that emerging public health issues may affect state or federal priorities. Grant priorities can also change the case definition. Also, each program can choose their own method of case identification. As with any surveillance program that would occasionally evaluate their methods for effectiveness, programs could be expected to evaluate and revise their program case definition criteria, as well as their definition of case identification. Hopefully, the program case definition criteria is clear and workable. Program-specific case inclusion, exclusion criteria. Our national case definition criteria, as defined by the NBDPN, are available on the NBDPN website under Birth Defects Surveillance Guidelines, Appendix 3.1, Birth Defects Descriptions. Some examples of categories to include are all structural and chromosomal abnormalities, a subset of NBDPN priority defects, live births only, all pregnancy outcomes, including stillbirths and elective terminations, only defects confirmed to be present after delivery by exam or by diagnostic testing, all defects, including those suspected but not proven. For example, those noted on prenatal ultrasound but not evaluated after birth. One of the purposes of this webinar is to help new staff understand birth defects. The field of birth defects encompasses a wide variety of health conditions. Because of this and the many state programs involved, it can be challenging to compare birth defect data across the states. By helping staff understand these challenges, we hope to facilitate the accurate comparison of data across states. And now let's discuss case identification methodologies. Case identification methodologies refers to the overall method that a program uses to identify birth defects, potentially meeting the case definition. In other words, it is the ascertainment method that the program uses to conduct birth defects surveillance. There are two types of ascertainment methods: active case ascertainment and passive case ascertainment. Note that programs could use an ascertainment method that combines features of both active and passive ascertainment methods. Passive case identification methodology. Cases of birth defects are reported to the program by the data sources. Examples of data sources include infant or fetal death reports. Another example is hospital discharge index reports that are ICD-10 based. Programs may choose to interact with the data sources to clarify the information reported, since interacting with the data sources could lead to improved reporting. Programs may choose to confirm birth defects with diagnosis verification. In addition, programs may choose to use additional criteria to validate that a diagnosis is real. For example, the number of times a baby appears in different sources with the same codes, or has certain procedure codes, such as surgery. Programs are not required to use diagnosis verification. However, not using diagnosis verification could lead to over or under counting the true number of diagnoses. On the other hand, using diagnosis verification could cost time and could lead to delays in completing cases. Program staff should seek direct access to records from the data source. Programs could use a quality audit that encompasses chart review. Active case identification methodology. Program staff directly access records at the data source or remotely. Prior to the advent of electronic medical records, even before COVID, it was harder for staff to review logs in nurseries or NICUs. Now, reports are received from a variety of departments within a hospital. For example, pathology, labs, and prenatal diagnostic centers. Staff use intensive methods to identify and qualify potential cases of birth defects. Staff review the records of potential cases to determine eligibility based on the program's case definition. Program uses clinical reviewer for complex, random, or specific cases following abstraction. Often, a clinical reviewer will notice something new or unusual about a case. They often recommend that certain cases are good teaching tools for abstractors. They may offer guidance on updating case definition or criteria. Disadvantages of clinical reviewers could be that it's more costly and time-consuming to access sites for reporting and for abstraction. Active case identification terminology. Case finding. It is the process used at each data source to identify cases of birth defects that potentially meet the case definition. This process may include reviewing all records with an ICD-10-CM discharge diagnosis code for a birth defect, reviewing all labor and delivery logs to identify evidence of a potential birth defect. For example, reviewing labor and delivery logs could help find cases where a baby dies there and an ICD code might not be generated. Reviewing the records of all preterm infants or stillbirths to look for a mention of a birth defect. Fetal death certificates might not capture all birth defect diagnoses, which would be picked up in a chart review of these losses. Case culling. Case culling is the process of reviewing the records of potential cases to determine which meet the case definition. For example, when conducting Zika surveillance, case culling would occur when cases were sought where there was less than a 50% chance that we would find cases that are positive for Zika. With case culling, you will always review more cases than you actually abstract. Even if you do not find a case at every review, it is still worth the effort. Now that we've completed case identification, we are ready to discuss data sources. Data sources are locations where programs may identify or obtain obtain information about birth defects potentially meeting the case definition. Such sources include hospitals, such as birth centers, pediatric centers, as well as general and diagnostic indices, genetic clinics, cytogenetic laboratories, prenatal diagnostic centers, vital records, and other state programs, specialty clinics, obstetric and pediatric practice offices, voluntary reports from individual physicians, administrative data sets such as Medicaid and hospital discharge data, statewide healthcare administrative databases. The strength of any birth defect program is multiple source ascertainment, as no one source finds everything. Your chances of having complete data is higher when using multiple sources. Review what is known about sources before adding it. For example, getting reports from doctor offices could be time-intensive. Another data source are birth certificates. While they are frequently used by birth defect surveillance programs, they are limited in that they tend to pick up severe diagnoses while missing the more subtle diagnoses, as well as the ones that are diagnosed after the newborn period. New and emerging data sources. HL7 stands for Health Level International 7. This is a set of international standards for transfer of clinical and administrative data between software applications used by various healthcare providers. This data features electronic health records. Data hubs is another type of an emerging data source. A third type of emerging data source is all-payer claims databases. These are claims databases used by insurance and other payers, such as Medicare. Note that not all states use these data sources. So, if you want more information on these data sources, you could ask staff from other birth defects surveillance programs. Now that we have reviewed surveillance terminology and concepts, we are ready to discuss the guidelines for pre-abstraction. Let us begin the second section entitled Pre-abstraction. Now I'm going to cut here